Hello, I'm Dr. Mark Stovak, Medical Director for Via Christi Sports Medicine. This is Amy Cahill, our athletic trainer extraordinaire with sports medicine and head athletic trainer at Independent High School. We're going to do a physical exam video for you today to give an example of a basic joint exam for all of the joints, starting with the ankle. So the first thing that we start with when we're examining a joint is inspection. And when you look at Amy's foot and ankle here, the first thing that you want to look for is swelling. Go ahead and raise your ankle up. And right here in this somewhat dead space, and then if we rotate our ankle out, and in this dead space, you'll see that there's somewhat of a hole, and that's a normal joint. If it's swollen, it will swell in this area here and in this area here. You look for bruising, other areas of trauma, and then from there go on to palpation and try to find the areas that hurt. Usually you pick the areas that hurt the most last. So first, to start with identifying landmarks, on the medial side you have a wide deltoid ligament and the medial malleolus of the distal tibia. You have the posterior tibialis tendon, which comes down and inserts on the medial navicular. If you follow that across, you can find the end spot where you get a navicular stress fracture, and it's easy to identify that because you have them raise their big toe, and you identify the extensor hallucis, and then you have them raise their ankle to identify the anterior tibialis, and the spot right between the two is the end spot. Next, you can find the dorsalis pedis pulse just next to the extensor hallucis, this line here. You can find the joint line just by palpating across the soft spots here of the joint. And then the lateral structures, you can identify the base of the fifth metatarsal, which is often fractured in ankle sprain. But just behind that is the cuboid. Just behind that, the soft spot is the sinus tarsi. And then your ligaments, which often are injured in ankle sprains, the anterior talofibular ligament, the calcaneofibular ligament, and the posterior talofibular ligament. And then you identify the peroneal tendons coming down and inserting on the base of the fifth metatarsal. The other structure which is injured in a high ankle sprain is the anterior tibial fibular ligament, which is just above the joint here. So once you've palpated the important anatomy to figure out exactly where they're sore, then the next thing that you want to do is have them do range of motion. Usually when they have injured their ankle, they'll come in with their foot in plantar flexion because it's swollen and there's more room in the joint in that position. So the first thing that you have them do to work on motion is you have them plantar flex to identify how far they can go down, always comparing it to the opposite good ankle. Hopefully there's a good ankle. Then you have them dorsiflex to see if they can get as much dorsiflexion as possible. Then you have them evert the ankle, and then you have them invert the ankle, comparing range of motion. Then beyond that, you can have them raise their toes. Usually the toes don't move very much, but you can always see that the great toe, and it should raise about 70 degrees of motion. If it doesn't, it's called hallux limitus. Then you have them flex the toes. Next, you can do all of those against resistance, where you have them, you resist against their dorsiflexion, you resist against plantar flexion, and so on and so forth to test muscle strength and to see if they have pain with firing those tendons. So after looking for swelling, doing inspection, palpation, and testing for tendon strength, you can start testing for ligamentous laxity. The first test is the anterior drawer, which tests the anterior talofibular ligament. The easiest way to do the anterior drawer test is to put your top hand on the tibia and fibula and to cup the calcaneus with your bottom hand. Push back with the top hand and pull with the bottom hand in order to apply some traction to that ligament. And you want to do this as hard as the patient will allow you to do it. The next test is the talar tilt, or the inversion stress test. And on that test, you're testing the calcaneofibular ligament. And the best way to do that is to do a very similar exam. However, instead of pulling forward with the bottom hand, you twist the ankle into inversion. And you just test for laxity. You want to do this again as hard as the patient will allow you to do it. Those are the ankle ligaments that are injured in an ankle sprain. The posterior tibialis is the third ligament, which is, there's not a good test for that ligament. The next test is to test the anterior tibial fibular ligament, which is what is injured in a high ankle sprain. One way to do that is to do a squeeze test where you just squeeze the tibia and the fibula together. And you want to note how far up the syndesmosis, the area between the tibia and the fibula, they develop pain. Another way to do that test is to forcefully dorsiflex the foot and then externally rotate the foot or the ankle, and that will stress the tib-fib ligament. And that is what is injured in a high ankle sprain. Once we've done the ligamentous exam for stability, the last thing that I test for is palpation of the Achilles and the retrocalcaneal bursa, which sits just anterior to the Achilles tendon. Another way to test to see if they're having bursal pain is to forcibly plantar flex the ankle and pinch that structure, which sits right back in this soft space anterior to the Achilles tendon. That concludes our foot and ankle exam. The next thing that you can have them do is stand to look at their arches and walk to evaluate their gait. But as far as the joint exam, which we wanted to point out, that would be a basic joint exam. Okay, the next joint exam that we're going to do is the knee. And we'll start again with inspection, and then palpation, and then range of motion, and then specific testing of different structures. So the next thing the first thing we want to look at with the knee exam is inspection. And you want to look for swelling. So the first thing that I have them do is tighten up their quadricep muscle, and you'll notice that there is a divot here and a divot here. If they have a joint effusion, that divot will fill with fluid. If it's fluid in the bursa sac, the fluid will actually sit here on top of the kneecap, and you'll still have your divots. And if you squeeze the skin, that will hurt the bursa sac. So once we've seen where the swelling might be, the next thing that we want to do is have them do active range of motion. So we have them extend the knee fully, and she can actually hyperextend her ankle a little bit. That's knee recurvatum. And then we have them flex the knee as far forward as they can with the heel slide, always comparing it to the other extremity. Once we have range of motion, the next thing we want to do is identify the structures that may hurt through palpation. And I normally start with the patella and the structures around the patella. So first you have your quadriceps tendon, and I'll usually have them tighten up their knee and palpate across the quadriceps insertion onto the patella. Then I'll go to the bottom of the patella and push on the patellar tendon origin on the patella, and then follow it down to the insertion on the tibial tuberosity, where you develop Osgood-Schlatters disease in a kid. If you have pain at the distal patella on an adolescent or a child, that is Sinding-Larsen-Johansson syndrome. Once you've palpated along the patellar tendon and identified possible Osgood-Schlatter or Sinding-Larsen-Johansson disease, then you want to palpate along the medial and lateral patella. Palpating along the medial patella, you have the medial retinacula, which attaches the patella to the distal medial femur for stability. You can have what's called a medial plica band, which is a band of tissue, feel like a bowstring when you rub your fingers back and forth. Then you can feel for tenderness along the lateral patella. You can move the patella medially and laterally and feel underneath the patella to see if there's sore underneath where you might get pain with patellofemoral syndrome. Then you can go down to the area of the proximal tibia where you have the pes anserine bursa and palpate there. Oftentimes they'll get local swelling there when they have pes anserine bursitis, and that's the attachment of the crow's foot for the gracilis, sartorius, and semitendinosus tendons. Next, I usually bend their knee to 90 degrees, and then you can feel the joint line. And I'll start to feel the medial joint line for tenderness, either from arthritis or a meniscal tear, or the lateral joint line. And oftentimes, if you have a hard time identifying where the joint line is in a very large patient, you can at least find the fibula. And when you find the proximal fibula, then you can find the joint line just above it. Now you can also palpate the hamstrings in the back, which is hard to show in this video, but the the biceps femoris is attaching to the fibula, and the semimembranosus and tendinosus are on the medial aspect. And usually when they tighten up their hamstrings, you can identify those structures and see if they're sore. Once we've done observation, range of motion, palpation, then we move to specific testing of different parts of the knee. Usually, again, I'll start with the kneecap, and I'll start doing some tests for patellofemoral syndrome. The first one is Clark's sign, where you hold the proximal patella down with some force, but not a lot of force. If you hold it too hard, you'll hurt anybody. So you hold it with just a little bit of force, then you ask them to fire their quad muscles, and you just give them some resistance down on the patella. And then I usually have them do that twice. The ones that have bad patellofemoral syndrome will know that that's going to hurt, and they'll be very apprehensive or tentative, whereas those that it really doesn't bother will just fire right through your fingers. The next test is the lateral apprehension test, where you put your fingers medially on the patella and you push laterally as hard as you can. And if the patient has had a patellar subluxation or dislocation, the patella usually goes laterally, and that will cause the chandelier sign. Well, they'll jump off the table, or that'll really bother them. The next structures that we want to palpate, or next structure that we want to test, is the meniscus, which sits in the joint line. And there's several ways to do this. One is the McMurray's test, and then for that test, I'll usually put my fingers on the joint line in a C-shaped fashion, and then cup the heel with my other hand, and then just flex them, flex the knee, and then internally and externally rotate the tibia. Then extend the knee and doing the same thing, and then kind of do it as one big motion. And if they say that that causes joint line pain where my fingers are, then that can tell you which meniscus may have been injured. The next structure that you want to test is the anterior cruciate ligament, which keeps the tibia from translating forward. You do that by doing the Lockman exam. You want to put your top hand across the femur and the quad muscle, and the bottom hand across the tibia, oftentimes your finger near the tibial tuberosity. And then the most important thing is getting them to relax their quadricep muscles and their hip flexors while you're doing this. Then you have to raise them to about 15 degrees to 30 degrees of knee flexion with your top hand, making them comfortable that you're not going to drop their knee. Then with some downward pressure with the top hand and some upward pressure with the bottom hand, you want to stress that ligament. And you should feel a nice snap when that ligament becomes taut. If you have a soft end point or it's a lot looser than the opposite side, then that is indicative of an anterior cruciate ligament tear. Next, I'll usually bend the knee again to 90 degrees and feel for a posterior cruciate ligament tear. And oftentimes on that, if you just put your fingers right down on top of the tibia, you should hit the top of the tibia. If your fingers do not hit the top of the tibia and go straight down the tibia, then the tibia is sitting backwards, indicative of a posterior cruciate ligament tear, and that's called a sag sign because the tibia is sitting backwards. The other way to test that is to sit on their foot, put your thumbs on the top of the tibia on the joint line, put your palms of your hands on the tibia, and push backwards. And that should not move backwards, but a couple of millimeters at the most. Again, always comparing to the opposite uninjured knee. And that's a posterior drawer for posterior cruciate ligament stability. Next, another way to test for the ACL is the pivot shift test. With that test, you want to put your hand, your top hand on the lateral joint line, your bottom hand cupping the heel, and you want to flex the knee while applying a valgus stress medially to the knee. And what you'll feel is a thunk as the tibia subluxes and reduces back and forth at the knee. That's probably the most difficult portion of the knee exam, is to get a good pivot shift down. The next thing that we want to test is the medial collateral ligament. That extends from just above the joint line on the distal femur to below the joint line on the proximal tibia. And the best way to test that is to do an exam somewhat like a pivot shift, but you cup the heel underneath your hand and put it up in your armpit. Then you put your hand on their calf. You put your top hand on the lateral joint line, and you keep their knee fully extended, and you apply a valgus stress across the knee joint without rotating the hip. With the knee extended, the joint should never open. If it opens, that means not only do you have an MCL injury, but you also have an ACL or a PCL injury. Next, you just want to bend the knee 15 to 30 degrees and do the exact same valgus stress to the MCL without rotating the hip. And on this, the easiest thing is to feel not so much the opening of the joint, but the closing of the joint as it returns to neutral. Again, comparing it to the opposite knee. To test for the lateral collateral ligament, which extends from the distal femur to the proximal fibula, you do the exact same exam as you did on the medial MCL, but you put the foot into your opposite armpit, and you put your hand on the medial joint line, applying a varus force. Again, first with it extended, and the joint should never open in an extended position unless you've injured not only the LCL, but also the ACL or the PCL. And then again with the knee bent about 30 degrees, making sure that the patient is comfortable, that you're not going to drop their knee, and then applying a varus force without rotating the hip to the knee joint. And again, it's easier to feel the closing than the opening of the joint. Once you've tested all the major ligaments, another good test to do at this point of the exam is the hyperextension test of the knee, where you just bend the knee, and then somewhat in a surprising fashion, you let go and let the knee fall into the extended position. This exam is very good for testing what's called fat pad impingement syndrome. The fat pad sits right behind the patellar tendon, and oftentimes they'll get anterior knee pain when that fat pad gets pinched in the joint line, similar to biting your cheek while you're chewing your food. Once we finish examining all the structures individually, and we finish with the ligament exam, the last thing that we do is test for strength. So normally we'll have them bend their knee to 90 degrees and pull their heel to their buttock, testing for hamstring strength. And then we'll have them push forward against resistance from the hand to test quadriceps strength. And that really is all of the strength testing for the knee. Okay, for the knee exam, the last part of the knee exam that we often do once we get the person off the table is to put them in the middle of the room and have them do some different maneuvers to look for specifically meniscal pathology. And the first one we do is called the Thessaly test. And basically you have the patient get their balance and stand on one leg, and then bend their knee about 30 degrees, and then internally and externally rotate their tibia by rotating. And you see if that reproduces their pain along the joint line. And if it's a person who has bad balance, you can grab their arms and just rotate them like you're dancing with them. The next test that we often do is just have the patient duck walk and see if it reproduces their pain along the joint line of their knee. And then usually when they're down and they start to have pain while duck walking, we'll have them put their finger in the one spot that hurts to see if the pain that they're actually having is really on their joint line where their meniscus is. And that would pretty much conclude the exam of the knee that's not done on the table. The third exam that we're going to do today is the hip exam. And usually when the patient comes in pants, you want to get them into some shorts. But it's still hard to identify through shorts the different structures or where they might have swelling. So usually we'll ask them, where it hurts, and then lift the shorts and just kind of look at the different areas and make sure they don't have any bruising or swelling or abrasions or other things that might be contributing to the problem. So once we've done some observation, you want to make sure that they don't have any abdominal pain. So oftentimes we'll make sure that there's no pain to palpation in the belly. And then we'll have them do range of motion. So we'll start with hip flexion. We'll have them raise their hip into flexion. And then we'll have them do hip extension, and we'll have them slide off the table and extend the hip, stretching the hip flexors. And come on back. Then we'll have them do active abduction of the hip, where they pull their leg out, and then adduction, where they pull it back in. And once we've done all the range of motion of the hip, that way we'll often have them internally and externally rotate the hip. So external rotation and internal rotation. And that's somewhat confusing because the foot's going in the opposite direction. When the foot goes out, you internally rotate the hip. When the foot comes in, you externally rotate the hip. So now we've done range of motion, so then we'll usually start to push. And again, we'll often push on the belly. And then you can identify the anterior superior iliac spine, the bony prominences in the front of the pelvis. You can identify the pubic bone and the pubic symphysis. You can identify the inguinal ligament between those and any lymph nodes and the femoral pulse. You can identify the iliac crest, which goes from the